Welcome to the webinar. You are participating in the webinar entitled Innovate Your Medication Education, Mr. Ed, Utilizing Technology for a Patient-Centered Approach to Medication Education. This webinar is part of the Medication Safety Best Practices webinar series dedicated to share best practices from awardees of the Award for Excellence in Medication Safety. During the time together that we'll spend, we will discuss the complexity of medications in chronic disease state management with a special focus on medication regimens used in solid organ transplantation, describe strategies to enhance patient medication teaching utilizing technology, and summarize methods that technologies can be implemented to improve patient engagement. My name is Dimitra Tepepis. I am a transplant clinical pharmacist and currently working as the Director of Quality and Research and Kidney Transplantation at New York Presbyterian Hospital, Columbia University Irving Medical Center. There are no relevant disclosures among the faculty, planners, and ASHP staff pertinent to this activity. In order to process your CE, ACPE requires all pharmacy continuing education credits be processed and claimed no later than 60 days from the date of a live activity. Please be sure to process your CE after this webinar using the online system available at elearning.ashp.org. With that, I'd like to get started. New York Presbyterian Hospital has a long-standing history. The organization is comprised of two major medical centers that initially began as the New York Hospital in 1771. New York Presbyterian Hospital was founded in 1868, and in 1998, the two hospitals merged to form New York Presbyterian Hospital. The organization is affiliated with two major medical centers as well as medical colleges of Weill Cornell Medical College and Columbia University. New York Presbyterian Hospital is committed to excellence in patient care, education, and community service. We're comprised of several sites and centers that make up this whole health system. In the Department of Pharmacy, the mission of the division is to help people make the best use of their medications. In transplantation, we have an armamentarium of medications comprised of approximately 15 agents. These medicines are critical for the patients as they progress in the post-transplant setting. We see here, over time, drugs have been developed that have reduced rejection rates indicated by the red line. Over time, we see reductions as new drugs are developed. As well, one-year survival rates, as these new medications are developed, they begin to improve. However, this is very complicated. So this is a very typical regimen that transplant patients are required to take and to learn about. They see the medication list is comprised of many, many medications, and this picture is actually not atypical. It really does look like this when patients are trying to put their pill boxes together. So if you take a moment to think about how long it might take your elderly family member or somebody that's not familiar with healthcare to learn about these medications, it can be quite difficult. There is significant impact of complex medication regimens. So in our patient population, in a sample of 190 kidney transplant patients that I interviewed at our clinic, it was quite striking to find that some patients were forgetful, 10%, and would not take their medications. Some were careless, and the patients even stopped taking their medications when they were feeling better or worse. I'm going to spill the beans pretty early in this presentation about the exciting outcomes that we've had with this novel implementation of medication teaching. So complex medication regimens do lead quite frequently to hospital readmissions. And so in our standard teaching practice, compared to our medication regimen education tool, for which we were awarded this honor, we actually were able to reduce 30-day readmission rates, one-year readmission rates, as well as the mean number of readmissions that patients experienced after kidney transplantation. Standard teaching was conducted as in-person sessions, and I'm going to go into a lot more depth about what the Mr. Ed regimen and teaching module is all about as we progress forward in the presentation. One other very exciting outcome that we had as part of this initiative was reductions in rejection rates. So antibody-mediated rejection occurred less frequently among patients that were educated about their immunosuppressive medications using our novel teaching tool. In transplantation, we actually have three very distinct phases of care. In the pre-transplant evaluation phase, the transplant phase, which happens in the inpatient setting, and then post-transplant and lifelong care. It's very important that we engage patients in each of these venues and each of these locations, as well as each transition and pivot point as they move from one setting to the other, from the home setting to the hospital setting and back to the home setting. Transplant pharmacists are required elements from the Center for Medicare and Medicaid Services, or CMS, and the United Network for Organ Sharing, which are governing bodies that transplantation is overseen by. And so as transplant pharmacists, we participate on the medical teams to monitor pharmacotherapy. We communicate medication issues both with patients as well as healthcare providers, and are required to perform patient medication teaching during various specific points before and throughout the hospitalization. In preparation for this presentation, as well as some other presentations, I sent a survey out to the transplant pharmacy community and received 65 individual responses from individuals practicing at 60 unique transplant centers indicated in the map. It's very interesting. 100% of patients were educated during their index transplant hospitalization. And I've just mentioned that we're governed by CMS and UNOS, which require this function to be performed. 97% of respondents indicated that the pharmacist was the individual responsible for the medication teaching. There's also participation from floor nurses and transplant coordinators as well. During the index hospitalization, meaning the time that the patients receive their transplant, clinicians are spending about an hour and a half educating patients. Something that's quite striking is that during hospital readmissions, which are quite frequent after transplantation, only 14% of respondents indicated that they were actually continuing to educate patients in the inpatient setting. And they were spending 1/3 of the time during this readmission phase as well. In identifying what are sort of best practices or what are methods that clinicians are using to teach their patients about their medications, there are very traditional sources. So medication lists, medication classes, providing handouts, using teach-back, which is important, and also performing pillbox filling. At New York Presbyterian, we had an opportunity to collaborate with the IT division to develop a novel medication teaching method that really transformed the way that we actually practice, as well as created this transformative technology that brings to life information to the patients so that they can learn about their medications. There are several key elements to our digital medication teaching method, which make the tool incredibly useful and versatile. Most importantly, our approach is built on a platform that is flexible and adaptable. It has enabled us to present content to patients in an interactive manner. Medication teaching modules are accessible on both web and app platforms for ease of use, and they can be shared with patients via email or text messaging. Video streaming of our engaging content appeals to a broad audience, including adult and pediatric patients and individuals with variable healthcare literacy and even sensory impairments. Unlike previous tools, ours has the ability to teach an entire medication regimen rather than a single agent. Furthermore, it allows the individualized medication collection of information. All of our content has been vetted through patient education committees and has been translated through interpreter services into multiple languages. We currently have the modules voiced over in Spanish at the moment. In addition, we've embedded dynamic questioning and quizzing that generates customized alerts and real-time notifications with robust data reporting that allows us to intervene at the individual level when a patient, as well, and to expand our program based on patient needs and feedback. I'm going to take a moment to allow everybody to see in action our modules, a sample of our modules. Tacrolimus. Tacrolimus comes as capsules in 3 different dosage strengths and colors: 0.5 milligrams, 1 milligram, and 5 milligrams. Each transplant recipient will need a different dose of tacrolimus, so we use 2 or 3 strengths to make the dose that's just right for you. We measure tacrolimus blood levels often to see how much tacrolimus is in your bloodstream. Your tacrolimus dose will be adjusted to make sure that we prescribe the correct amount and target the correct level for you. The tacrolimus dose may increase, decrease, or even stay the same after each measurement. In our case study, patients watch the teaching video content, which is followed by quizzing to assess their knowledge gained. This way we can identify knowledge gaps that still need an in-depth follow-up and during the in-person discussion. This makes the sessions more meaningful and focused. This is then followed up by knowledge reinforcement, which is provided by explanations to a particular question. Overall, for patients, this has had a profound impact. There is improved access, where the video clips can be watched over and over, rather than just having a single or maybe two inpatient sessions with a pharmacist in face-to-face contact. In addition, there's a consistent message so that all patients are learning the same information regardless of the specific provider that they're meeting with. There is now the ability to dynamically generate quiz data that enables us as clinicians to have a follow-up conversation that addresses the knowledge gaps that have been identified and provides specific knowledge reinforcement to ensure that patients are fully aware and understanding their medication regimens, thus improving the safe use of medications. From the clinician's perspective, this process has revolutionized our practice in the creation of a more streamlined workflow with shortened in-person session times that allow us to perform other tasks related to medication management and quality. In addition, we're able to collect feedback from patients based on their interactions with the software, where we can receive questions that they have in a free text format, and we can expand our materials in a meaningful way and provide them with additional education as they need. I'd like to share some of the outcomes that we've had with this implementation. In a subjective assessment of the patient's understanding of their medications, we ask patients, how well do you think you know your medications? The gray bars indicate their knowledge base prior to receiving the medication regimen education through our innovative technology. We can see, and the red bars indicate their knowledge, subjective knowledge about how well they think they know their medications after using our medication teaching modules. And we can see that there's a transition from gray to red, where patients really feel in the beginning that they don't really know anything or they only know a little, and then they feel more empowered that they know everything following the medication teaching modules. To become objective about it, we actually have 19 assessment questions that each patient receives. I've categorized these into two domains, indication and instructions and side effects. So in our transplant education module, we have 14 questions related to indication and instructions, and 90% of questions that are asked of patients have been answered correctly, indicating that they have gained adequate knowledge about these, about the details that they need to be aware of. Side effects is a little bit more difficult, so we have 5 questions about side effects, and 62% of patients are answering those questions correctly. So there are opportunities in that realm. In asking patients, was receiving digital medication effective via the tablet method? We see here in the graphic that 96% of patients are actually, 90% of patients feel that they did adequately receive education and it was effective via digital technology, ranking this as a 4 or 5 out of 5. It is always important to reflect and look back at how can this be done, and how can we develop this process, or how can we implement the process, and how can we further enhance the modules as well. So to start, I'll review our methods for digital education development. The first step was to identify the medications. What is the population that we want to serve, and why is this an appropriate population? So I've already demonstrated in the background that transplant patients require very complicated regimens. There's lots of rules, there's a lot to learn, and it's several medications all at once. Step 2 is to create a template. So what we call a storyboard is essentially similar to a monograph, and I have a template on the right side of the slide of this standardized speech, if you will, of the type of information that we have. So we relay the message about what is the patient taking, what is the medication being used for, what are the minor side effects, what are the major side effects that need further escalation to a clinician, and then important things that need to be kept in mind. We then develop slides that are indicated in the middle graphic within the slide deck here, And we've created the content so that it's engaging and interactive and brings some enlightenment and lightness to the fun to the actual modules. We then convert these PowerPoint slides actually to digital video content and upload them through our platform and they're ready to use with patients. Over time, we've created a quiz monitoring dashboard. So every few weeks, we actually keep track of how patients are doing with our medication teaching modules. And so there's the scope of the question, the actual medications, and we use this dashboard. We've used this over the last year and a half to augment our teaching materials as well as evaluate our actual patients to see where knowledge deficiencies exist so that we can intervene further. I'm going to review some enhancement steps that we've taken. So this question that I'm summarizing here is related to tacrolimus side effects. So in December 2015, we implemented a change in the way that we deliver the education. So side effects was an area of opportunity that I identified already. We had some patients that could benefit further, and our process could benefit further. So in the initial period, in the initial rollout from February 2015 to November 2015, only 62% of respondents were answering this question correctly. And the way that we were teaching this material was to essentially create a list of side effects just by text. What we did to enhance this in December of 2015 was to bring this text to life by including images and pictures that were hopefully, that the idea was to bring memory and add some perspective to these side effects so that patients could actually remember how they learned these medications through these images, which might actually even be quite comical, if you will. So following implementation and following improvement of the method of our teaching delivery, we actually saw an improvement in our response rates, where 73% of responses were answered correctly. A second enhancement that we've made, I'm going to highlight three, was related to mycophenolate safety, and this took place in March 2016. Mycophenolate is associated with a pregnancy warning, and so we stratified the responses, which relates to female patients. And so we stratified responses by female and male patients, and how were patients answering these questions correctly. We actually identified that some male patients were answering this question inappropriately because the information didn't apply to them. And so what we decided to do was actually change the question. So in the bottom half of this slide, for all patients, initially we were asking the question in the same fashion. And now for female patients versus male patients, we actually changed the responses so that the full, the gamut of response rates, responses that males would have would actually be tailored to them. And the responses that females needed to respond with were tailored to them as well. And we saw an improvement, a marked improvement in the correct responses provided by males. We didn't necessarily see, though, an improvement in the female cohort, and so we took a second step. We actually added a second module specifically related to mycophenolate REMS education just for female recipients and voiced over additional content that was specific to this particular issue, which is very important for transplant patients to be aware of. A third enhancement has to do with a drug administration rule that we teach patients about. So we have what's called the 4-hour rule. So if patients forget to take their medication, we inform them that they should take the medication if it's within the 4 hours of the missed dose. Initially, patients were responding, 63% of patients were responding correctly. And so we had all of the information on one slide. That's indicated on the left half of the picture. We didn't have an example, and it was just very basic, and we would voice over and they would watch that one image. In April of 2016, we actually split this into additional slides. So we've turned one slide into 5. And so we added, in that process, we also added an example. And so we gave them an example that they'd have to rhetorically answer while they're watching the video. If it's 9 a.m. and it's 11 a.m., should you take the medication? And the answer is yes. If it's 9 a.m. and it's 3 p.m., should you take the medication? And the answer is no. And so we gave them more tangible examples to actually learn the information, and it really did work with a 20% increase in response rates being correct. following implementation of this for transplant patients, there was definitely opportunities and desire throughout the organization to expand into other therapeutic areas and other patient populations. And so we did this strategically, and we expanded it to areas of patients that are considered high risk, or patient populations that were using medications associated with significant safety concerns. And so we have some expanded applicability, particularly related to heart failure patients, anticoagulation, oncology, and other medication profiles and patient populations that require medications that have a lot of rules, just like transplant patients. Should we take it in the morning? What are taking it before or after blood draws? Taking it with food? Cutting medications, crushing medications, etc. And so we've actually expanded from our armamentarium of transplant medications, where we have about 15 modules, to having a multitude of a library of medications in use, including anticoagulants, antimicrobials, asthma medications, bowel regimens, which all patients throughout the organization are on and throughout in healthcare, diabetes and endocrine, GI, use in therapeutic areas like gout and cholesterol, hypertension. We expanded some immunosuppression, pain, and in psychiatry as well. This is an image that indicates our digital education development process. So we initially began this process in April of 2015. There was an expansion stimulus when this was presented to leadership within the organization, and the desire to further expand beyond transplant really took effect in the fall of 2015, where up until today we've created to completion 76 modules, and we have storyboards we have some sort of process in place for 143 modules as well. And we've expanded into all of the therapeutic areas that I've just described, and are further implementing this throughout the organization. So in addition to creating more modules, we're actually going to additional nursing units and applying this methodology to other patient populations throughout the organization and all of our various campuses that we have at New York Presbyterian Hospital. We have some very positive findings as well. So we've implemented this pretty broadly, and so we have over 1,200 respondents or participants and patients that have utilized this type of learning to date. So this is split up a little bit differently in that we evaluated, this is subjective information about was this education helpful for you to understand what your medicines are for. So now we're moving into actually the HCAHPS questions and domain, where patients are filling out questionnaires about indications and side effects. And so the majority of patients are indicating with a 4 or 5 out of 5 on a 5-point scale that they do find that this methodology and this teaching method is effective for them to learn about their indications. And the same holds true about side effects. So was this education helpful for you to understand the possible side effects of your medication? Patients seem to be very satisfied with this information as well. Really interesting to me is that we also ask additional questions. And so a lot of these medications that we're teaching in the more broad sense beyond the transplant immunosuppressants are oftentimes drugs that patients are taking for quite a long time. So HMG-CoA reductase inhibitors, for example. And these patients are actually, we're asking them, did you learn something new? And 92% of respondents, despite watching modules on drugs that they've been on and medications that they've been on for quite some time, 92% of individuals are saying that they still learned something new. So that's very exciting and it's an interesting finding. All patients following this medication teaching module feel that they're prepared to manage their medications when they go home. And interestingly, about 60% of patients are interested in having access to these digital videos while they're at home. The majority are preferring that the modules be sent via email, and we're able to do that because of the nimble nature of our technology that's been utilized and implemented. This is one of my favorite slides in that we asked them what is the best thing about receiving medication education on a tablet. And these are actual patient quotes from a free text module that we have where they think it's a really cool process, it's really fun and easy to use. Patients are really satisfied that they could learn at their own pace, and they can really repeat sections that they're unaware of and watch it with their family members as needed. They've had very positive experiences that they can go back and repeat information When we were meeting with them one-on-one, they felt that it was a one-shot deal, whereas with this, we are actually providing them a tool that they can use repeatedly in the hospital and then use at home as well. A lot of satisfaction around that it was fast and easy to follow. They're going to have they have opportunities to process the information and take notes as well. In terms of providers, there are also very positive findings here. It's easy to use and saves time, so they can do more in-depth medication reviews as they're profiling orders for patients, the clinician side. And they're able to provide, the clinicians feel that there's the ability to provide a consistent message in an engaging manner, which we've talked about previously. The clinicians set this up for patients to learn at their own pace with their families, so they could leave, and we deliver the education via tablet, iPad devices. We could set the whole module up, leave it with the patient, and so if their family comes when we're unavailable, they're ready to set up the modules right when their family members are available and ready to learn with them. And then there's been another exciting part, this is beyond pharmacy, is that some of the nursing staff and nutrition and dietary information there's been a lot of requests and interest in collaboration for wound care, nutrition information, discharge instructions, and the like. So in conclusion, utilizing digital medication regimen teaching, it really improves healthcare delivery. We're able to provide a consistent message, enhance efficiency and workflow for clinicians, provide high quality medication teaching, and really improve outcomes. If you recall, we have lower readmission rates in our lower rejection rates in a relatively high-risk patient population. And it's really important for healthcare organizations to adopt engaging programs that really empower their patients to take an active role in their care. And this module has really provided patient-centered care for patients throughout our organization. Some key takeaway points from our experience are that patients who understand their medications are less likely to be readmitted to the hospital. Interactive technology allows patients to control their acquisition of knowledge at their own pace. And technology can enhance patient engagement as well as provider workflows. And I hope I've demonstrated that effectively throughout our process. With that, I'd like to thank you for your attention, and I will be opening up for questions, but we do have 2 quick assessment questions to review in the next slide. So the first question is a true or false question. All of the below characteristics are important components in developing innovative, novel, patient-centered education programs. And the characteristics would include interactivity, accessibility, engaging content with appeal to adult and pediatric patients, variable healthcare literacy, as well as patients with sensory impairments, the ability to teach on an entire medication regimen rather than a single agent, availability in multiple languages, dynamic questioning and quizzing, alerts and real-time notifications, and data reporting. And so these are all elements that the answer is true. So these are all elements that have been embedded throughout our modules and throughout our process development. And then the next question is, which of the following technology supports patient-centered care? A USB memory stick is choice A. Choice B is tablet devices. Choice C is interfaces, or D, none of the above. And the answer here is tablet devices. So these are tools that can be used in a mobile fashion and provided to patients so that they can use the information to use the tablet devices to learn about specific information. So with that, I'm actually going to move to the question aspect of the presentation. So this is actually a very important question. We have a question about the CE code. And I do have the CE code for everybody to jot down. The CE code is 17007. So I'll repeat that one more time. It's 17007. Our next question is, and comment is, great work. Were you able to use an instructional designer to help with the content creation. So that's actually a really, thank you for the question. This content was actually created, interestingly, it's all on PowerPoint, and they're actually, I always think this is pretty cool to share with people. They're actually shapes within PowerPoint. So it's circles and squares and triangles all placed one on top of the other. So we have not engaged with a professional service to actually do the content creation, but we have internally created a database or a bank of images that we actually use from one module to the next, and we're trying now to create some variability and make the content ethnically diverse, diverse with age ranges, and really make the content more applicable to a broad population. Our next question is, does an educational expert assist with the development of content and/or ongoing enhancements? So the answer to this question is yes. So more recently, we've actually engaged with, so initially, actually, let me back up for a second. Initially, we had all of our content vetted through a patient education committee that we have at the organization, which is actually a requirement to vet any education content at our organization. More recently, we've actually reached out through our School of Public Health to some individuals that do specialize in patient education development for the ongoing enhancements. So I would definitely suggest that it is important both to engage early with these individuals, especially for the approval process, and the further enhancement of the modules as well, of any education content. Our next question is, how much did this project cost to implement? So there actually has been no cost associated. We did not put up front funds to support this modules. Our organization did contract with an agency that has some software that we use for actually intake. It's an intake survey software, and we have essentially, what we did is we transformed the intake survey software into an education tool. So the premise behind this project actually started with a competition, actually, where we had an internal competition through the IT Innovation Division, and an application for something called the I-Unit, where we actually submitted a proposal, and although my team didn't win the main prize, we did get access to this software program, again, intended for intake information, gathering information about the patient's demographics, family history, etc., and we transformed that into a digital teaching tool because there is video streaming capabilities. Our next comment is, outstanding use of tech for patient education and engagement. What are the demographics on your patient population on technology use and preference? Is there a difference with your younger age or socioeconomic status? Is there a provision to loan tech equipment to patients and caregivers? So I'll answer each of those questions one at a time. Our mean age of this population for transplant patients is 54 years old. And so there is wide variability. There are, we're using it in pediatric patients, we're using it in teenagers, in middle-aged individuals, as well as the elderly. We do engage the family for multiple reasons, not only to help with the technology use, but also because we want everybody to have awareness about the medication regimen that patients are about to go home on, which is critical for improving their outcomes and sustaining allograft function following transplantation. We anecdotally have seen some differences. I have overall very positive experience, predominantly because we've engaged family members to help with the patients that may have difficulty. In terms of access at home, we don't. The majority of our patients actually do have mobile devices, and it can be streamed on a mobile telephone as well as computers on the web, etc. I've even had patients that have gone to the library to watch these modules. So when there's a will, there's a way, I guess. And so we haven't had too many issues related to the lack of access. We do have a very diverse patient population in New York City, so we probably have seen the gamut of patients. And then in terms of, is there a provision to loan technology equipment to patients and caregivers? In the inpatient setting, the answer to that is yes. We actually do have iPads on dedicated to the floors where this material can be streamed from, but not for the home setting. We have another question about cost. Can you speak to the process of content review and approval and change control? I commented a little bit in the fact that we had approval initially and now have engaged an educational expert from our School of Public Health. We do have a dedicated group of pharmacists that do create the content and vet through what information is going to be reviewed. And so we meet weekly. We've now split into 2 teams in order to make sure that we can keep things moving along smoothly. But we essentially have engaged with individuals that have specialized skills and training in the various subpopulations that we're trying to educate. The question about, is the material available in other languages? So we currently do have the material available in Spanish, and we have our verbal data bank, or our text database, translated into Arabic and Simple Chinese as well. And so we're in the process of creating some of those modules into the other, using that to embed the new languages into our existing modules as well. Do you plan to offer these tools commercially to other organizations? We're working on that currently, so we're engaging with our internal strategy team here at the organization, and the content has been copyrighted within, all of our content has a copyright of New York Presbyterian Hospital on it, and we're exploring next steps in order to make this commercially available. And hopefully those of you that are watching this today and are interested, perhaps may be interested in looking into how we could potentially collaborate or work together to expand this, hopefully throughout the country. There's a question about, are you aware of any similar efforts for common medications for diabetes, COPD, and CHF? I'm not aware of that specific question. I am aware of some companies that do create modules for teaching related to overall health, but not specific to a particular medication. So this is strictly, or this is very dedicated and focused on medication teaching. There are companies that do more broad teaching that do exist, so I am aware of those. And in the literature, actually, there is literature to support use of digital medication teaching and video teaching. Publications exist around warfarin education predominantly. Another question is, outside of the transplant patient population, do pharmacists in other areas control the teaching or nursing services do that? So we do have a large team of clinical pharmacists at the organization. The subgroups that do a lot of medication teaching are those of us in transplantation where it's required. And then there's pharmacists that do medication teaching throughout the organization in internal medicine, some focusing in heart failure, antibiotic education. And what we've done now is actually we've expanded beyond just the clinical pharmacy group, and we've engaged our pharmacy interns to participate in this medication teaching practice on weekends in particular at the moment, where they are visiting select target areas where we have modules with medications related to those specific patient populations, so predominantly anticoagulation and heart failure at the moment. This is a logistic question. How do you clean the tablet devices between patient uses? We've talked with the infection control division at the organization. iPads existed on our floors around the time that we started doing this project or rolling out this project. We use specific Clorox wipes. Unfortunately, I don't know the actual product, but they have a purple top, and they've been. It would be important essentially to vet through the infectious disease antimicrobial group within each organization, and we've done that. The next question is, can you briefly describe the extra and types of FTEs that would be required to support your journey from transplant program to a total med ed program? So I may have touched on this. I'm going through the questions sequentially. I think I may have touched on this on a different answer. So we initially started with the transplant pharmacy group being the creators of this material, and we've expanded our team into having clinical pharmacists that specialize in a multitude of areas, and we meet weekly and create the content to expand this. Have you correlated your results with actual HCAP surveys? The answer to that is yes. Oops. I'm going to try to figure out how I can show you that data. So this is a slide that demonstrates HCAP's impact. So this is our transplant unit, where we see that when we started transplant education in February 2016, we see that there's a rise in HCAP scores. These are related to specific responses that were provided by patients that had this teaching. And then as we were only teaching about transplant education initially in the February to April time period. So we did quite well in the initial rollout, and then we dipped a little bit. But as we expanded our education modules to include more medications, we see that after April 2016, we had a pretty large spike in our HCAP scores, specifically on our transplant unit. And then this is another fun slide for those of you in the audience that have pharmacy students. This is actually our heart failure unit, and the stars in this, so time on the bottom axis, the scores on the Y, and the stars indicate when we had student educators. So we don't always have pharmacy students on rotation all the time, but every time we seemed to have a pharmacy student, or every time we had a pharmacy student, we would engage them in participating in this work and really going out and visiting with the patients, and students often like that type of interactivity with the patients. And we see that every time there's a star, there seems to be a spike that follows right after, which does indicate that there is improvement in HCAP scores when this is deployed. Another question is, do you know which e-learning tool was used to convert the PowerPoint slides to video format? It's actually all done within PowerPoint. They're converted to Windows Media video files in the saving process. What processes are you using to update information to address changes in practice or package inserts? So we have a bank that keeps track of the phase that each medication module is in, and when it was last reviewed, when it was created, when it was last reviewed, when it was deployed, and we have an ongoing review of this on an annual basis. It's a relatively new project, so we've gone through a couple of the modules from an annual review perspective. And then in real time, as alerts come out, we address changes in practice in real time. We had another question about the infection control. This is a good question. How long does each patient have the tablet in their possession? How many tablets are needed? And what is your transplant volume? So the modules, if they are completed in full, take about 40 minutes to an hour. So a lot of times we'll drop off a tablet, go perform other tasks, and then we actually get an email, real-time email alert when the module is complete by the patient. So they're about an hour, and we have 15 tablets. Our transplant unit has about 25 rooms. So not everybody is up for doing medication teaching all the time, and we're able to circulate the iPads pretty effectively. And in fact, that has even allowed us to take them to the other units as well. So 15 iPads is more than enough, and it seems to be working well for us. Question is, did you subdivide your professional feedback assessments by specific practitioners, examples, nurses, and physicians? So the feedback or the quotes that I provided on the slide deck are predominantly from pharmacists. And the last one was a quote where we shared our methods with the unit practice council that we have on our nursing unit. And that feedback came from a multidisciplinary feedback committee. The physician group that works on the floors where we're implementing this often does have a lot of questions, and they're pretty excited about pharmacy engaging in this fashion with med teaching. Do you provide a tablet and or go over the questions at the hospital prior to their discharge? Do you show them how to look at the material at home? So we do again deploy this material through a tablet device. We actually start teaching as early as possible. We try not to wait until the day of discharge. Even though there are medication changes that might happen on the day of discharge, we also teach them about their inpatient medications as well. So, and we identify that to the patient. This is an antibiotic, IV antibiotic that you're taking, while you're in the hospital for the next X number of days, and then we go back as often as needed to teach them about each change as it arises. And then, do we show them how to look at the material at home? Yes, we provide them instructions, and we also email them the information as well. If the education is supported by an app where patients can download it on their tablets or phone, yes. So the software that we use is available as an app, and it's also available to stream off of the web as well. So it's pretty versatile. How did you collect the data for results if it was in PowerPoint format? So actually the software that we use on the back end, on the building side of it, actually has the ability to download all responses, including actually time that the patients spend watching the modules. It actually keeps track of all of that type of timestamps on the back end, and it downloads everything into Excel. So we can actually just download in real time via a PDF that gets generated to our emails, or in aggregate when we're ready to do analyses and update our dashboard, we download the Excel files. Before this digital teaching tool was implemented, what processes did your hospital have in place to educate patients, and were these methods reflected in your pre-Mr. Ed data? Yeah, so the slide that I showed initially, let's see if I can figure out this particular slide in the beginning. So the standard teaching, this is transplant patient teaching. This standard teaching is essentially very traditional meeting with the patient, the pharmacist meeting with the patient and the family, one session of teaching and documentation in the medical record and so forth. Now as we've discussed, we let them watch the modules and then we follow up in the in-person session. do you have this technology currently used in transitions of care at NYP? So the answer to that is yes. We try to engage as patients that are on particular units, again, where we've deployed this methodology, everybody receives the teaching, and then for discharge teaching as well. So that transition to the home setting is certainly an area of education practicing. Another question is, how are you maintaining the education content in the modules? Is it a yearly review or quarterly? We've currently implemented a method for annual review and then in real time if things arise. At the moment, we have enough modules that we can keep track of. Another question is, what about the expense of providing tablets for the patients? Is there a tablet for each patient in each room, or is it checked out during the hospital stay? Is it used for other hospital departments and activities for education? So at the organization, there's an entire patient engagement team that has deployed iPads throughout all the nursing units. It's not per room, so we have 15 iPads and we have more than 15 rooms on the transplant unit. But there is a process. There is a box essentially where the iPads are stored, and actually it's quite interesting technology. When you plug the iPads in, they actually wipe out the iPad such that when you share from one patient to the next, information is not transmitted. So if somebody has and these iPads can be used for anything. They're open to use for anything that the patient chooses. They could check their email, they could go online, they could read the news, they could watch the medication teaching modules. There are other apps about wound care instructions and things like that, games. So it's really open source. And then when we plug them into this box, it wipes out the use that has been had, and it wipes out that memory, or the cache gets wiped, and it starts new for the next patient where the iPad gets used. How much time does it typically take to create a module for any given medication from creation to approval? So we have now the team of the team of pharmacists that's beyond transplant now. It depends. So we meet weekly, and we have now we've split up into a storyboard team and a PowerPoint team, and the group of the storyboard team creates the content and vets the information, and then the PowerPoint team essentially reviews the same information as a second set of eyes and creates the images, and then we have a process where the entire group reviews the final version before it gets deployed. How long does that take? It depends on the medication, and it depends on other ongoings that we have. So we have this is a project that's done on the side. It's not a part of the full-time functions that we have. So I would estimate that if we have a good track record, we could get something done in a week, one module in a week, and then if it takes a little bit longer, sometimes it could take maybe 3 weeks to a month. This is actually a very important question. Do you also provide written information? We do. So we have handouts that we use from online resources and commercially available products, like patient leaflets that are available online, so we provide those to the patients. And then the really unique thing about the software that we use is that it actually generates an email that comes to the pharmacy group, and we print that out and provide that to the patients when we go and have our in-person follow-up session. So they get information about all the ongoings. And the organization has implemented a discharge envelope where we're now putting this documents in the bigger picture throughout the hospital of the discharge envelope that patients take home with them. Are there plans to license these materials to other healthcare facilities? We're definitely we're getting close, and that's in the works. This is a good question and a tough one, perhaps. What are some challenges you have pinpointed so far with this technology? So what's really interesting is that if you look around when you're just walking anywhere, you probably will see people using their cell phones all the time. And it's in the news all the time. You can go to any website and you can see commentary about how often people use technology. But what's really interesting is that technology doesn't really get embedded into our work. It does, but it doesn't get embedded into our workflows. And interestingly, one of the challenges is actually initially, while this was being rolled out, there was hesitancy from the clinical side, from the clinician side of, you know, well, how we're going to lose our human touch and we're going to lose our human element, and are they going to know that the pharmacist is still involved, and so forth. And so I think that that was one of the barriers that I had to overcome initially, of all these questions of, well, you know, but I want to interact with the patient and so forth. And this really doesn't take away from that. It actually augments, because you're able to have specific conversations that are really benefiting the patient. So what I did is I took a step back and thought about this a little bit differently to respond to those inquiries of, it's not that you're not the face of the information, it's that you're able to provide a more detailed, in-depth discussion about specific things that the patient is lacking knowledge in. So it's really a thought process change in the use of the technology, in using technology to actually engage patients. This is another question is, who initiates the encounter with a tablet video, the nurse or the pharmacist? And that's actually a really interesting question. So we've really kept this within the pharmacy department. And so it's the pharmacists predominantly doing this, but we are piloting one unit where in the OB division, where postpartum the nurses are actually giving patients the tablet, and then we have embedded a question that says, would you like a consultation from a pharmacist? So we're handling it a little bit differently in just one unit. That pilot just started not too long ago, where we've done lots of training with the nursing staff on how to use the tool, and taking the approach of the pharmacist serving as in the consulting role. But predominantly we're having pharmacists really own this and really get out on the floors and interact with the patients. Do you use this in conjunction with face-to-face counseling or in place of it? We always have face-to-face counseling. It just happens at the end of the module, at the end of the teaching module. So patients spend as much time as they need. When we get that email alert, we go and we have that in-person conversation with them. This is how many tablets do you lose per week? Actually, we haven't lost any, which is perhaps surprising but really good. Another question is, are patients able to access the content after discharge? The answer to that is yes. We actually ask them for their email. So I'll switch to that slide. And individuals are really, so this is, when we ask the question, do you want access to the digital videos at home, 60% are saying that they would like access to the modules, and we're predominantly emailing them, but also text messaging to about 20% of patients. After converting to Windows Media file from PowerPoint, how do you make them interactive, and how do you save the collect the responses from the patients? So after they go on Windows, after they're converted to Windows Media video files, we actually upload them to a host server, and then we stream them through the software that we have. And the software is actually interactive, and they click on options to answer the questions. The patients will click on answers to the questions. The question is, can you share with the app name? It's called Tonic. Another question, how many FTE or extra pharmacy time was needed after Mr. Ed implementation to collect and analyze and document all the data? So because the software collects the data, that's automatic, and so there's a pretty seamless data extraction process that's automated by the patient, which is pretty neat. The analysis has been conducted by our team, so we have engaged some statisticians and done some work on our own as well. Is there an alternative teaching approach for any patient or caregiver that declines use of digital education? And certainly, yes, we adopt and adapt our teaching methodologies to specific patient needs, because ultimately we're here to serve the patients and make sure that they are understanding the regimens that they're receiving and that they're knowledgeable about their care. So we always engage them in the way that is most meaningful for them, but have had pretty good success with this tool. There's a question that came through about the languages. So we have it in English and Spanish, and then we have content translated, not in use yet, but in Arabic and Simple Chinese. Another infection control question, cleaning the tablets. And so I think I got through actually all the questions. I think the questions have been very good questions. A lot of them brought out additional information, so I'm glad that I had an opportunity to share those additional details with the audience. If there are no further questions, I think we're actually at the 1 hour mark, and so I'd like to thank everybody for joining in the webinar and the opportunity to present our work, which has been really exciting. And if there's one take-home message that the audience should have, is that when you're really passionate about something, don't let anything stand in your way, and push forward to achieve your goals and dreams, and good things will come. Thank you very much.